Hello, everyone. I'm Gary Berman from DevOps.com and the host of the Cyberhero Adventure Show. It's a pleasure to welcome you to another great DevOps.com webinar. Today, we're going to learn about bias and discrimination in AI healthcare models, an incredibly important and timely topic. But before we get to today's presentation, let's go over a few housekeeping items. As you see, we use the GoToWebinar system, and for many of you, you'll see the control panel. Please take a moment to click on the questions icon and the little downward arrow. This webinar is designed to be highly interactive with our great speakers. We welcome your questions, comments, and suggestions in real time, and we'll get to as many as possible. If for some reason we can't get to your question, we'll email the replies to you shortly. This webinar is being recorded, and the slides will be available to you on demand at DevOps.com in a couple of hours. Additionally, we have a great giveaway of 4 $100 Amazon gift cards at the end of today's webinar. So stay tuned to see if you are one of today's lucky winners. And now, a special thank you to our sponsors for today's webinar. Jeff Eystone is the Healthcare Advisor at CognitiveScale, and Tommy Sarnio is the Director of Innovation, Crowdsourcing, and Machine Learning and Segmentation at Kaiser Permanente. Jeff and Tommy, take it away.
Thanks, Gary. I appreciate it. And hello, everyone. Thanks to the folks at DevOps.com and Red Hat for hosting this discussion. I'm Jeff Eystone, healthcare advisor at CognitiveScale, where I work with our healthcare clients, some of the largest health insurance companies and healthcare systems in the country. And in the case of Kaiser Permanente, integrated delivery systems that are both payer and providers. We're supporting our clients with AI software and platforms that help to build and scale solutions in areas like cost of care, service experience, claims adjudication and enrollment, and pertinent to today's discussion, we have solutions that help our clients manage trust and deliver trusted AI solutions. So I really look forward to digging into the topic today on explainability and bias and machine learning models with you, Tommy, and discussing what is going on at Kaiser Permanente. So I'll turn it over to you for intros.
Sure. Hello, everybody. So Tommy Sarnio, I joined Kaiser Permanente 16 years ago, coming from consulting with McKinsey & Company, and thinking that my Kaiser Permanente stint would be a short one. Well, it's a compelling company with many opportunities. I've had a journey at KP that someone could view as a random walk, but I believe that I have systematically built a well-rounded understanding of the entire business of healthcare. I've worked twice for both the medical group and the health plan. During my tenure, I have built fee-for-service clinics. I worked in corporate strategy, playing an important role in developing Kaiser Permanente's quality and service strategy, and later KP's enterprise information strategy. I have had an operational role leading KP's neurosurgery service line operations in Northern California. I've built numerous analytic and operational business cases totaling about $500 million in total spend. And most recently, I have had a team of data scientists working for me, developing data and analytic products for emergency department utilization, social determinants of health, pharmacy utilization, and so on. My ambition is to set up tools, platforms, and processes where we can develop and deploy predictive models and other advanced analytic products at much faster rate than previous, yet maintaining all of the objectives, including impact, accuracy, performance, fairness, maintainability, and so on. I have a master's of science in engineering from Stanford and MBA from UCLA. Did you want me to give a little bit of an overview of Kaiser Permanente too, or would that be helpful?
Yeah, sure, Tommy, that'd be great. Thanks.
Sure. Okay. So Kaiser Permanente has 2.2 million members in across United States. We're not in all of the states. We're about 8 or 9 different states. We have more than 23,000 physicians, more than 60,000 nurses, and more than 200,000 employees in total. And our annual operating revenue last year was $84.5 billion. And if we were a publicly traded company, that would rank us at about 35 on Fortune 500. While we talk here, we'll likely have about 10 to 15 children born at KP facilities, and there may be on a more sad note, maybe 300 KP members who get admitted to an emergency room during our chat over here. So it's a large organization overall. We're probably talking to lots of analysts here that they're interested in that aspect of KP. We did some analysis a few years ago, and we estimated there might be more than 5,000 analysts at KP, including Medisay data scientists. Some years ago, we talked to the CEO of Kaggle, the data science competition company, and he estimated at that point that at least 100 KP employees had participated in Kaggle competition. So there's a lot of data science skill within the organization too. We do a lot of research as well. We have 180 full-time researchers and 1,670 research support staff, and we have more than 2,600 research studies currently underway, and we had 1,890 publications in 2019. So, and most of that sort of high-level, sophisticated analytic skill is in the research area, and also research is doing a lot of work in this fairness bias area as well. Because Kaiser Permanente model includes integrating both insurance and healthcare services and providing most of those services in-house, we have an incredibly vast and complete healthcare data. If you include the quantity of data we have and the ability to work on really meaningful problems like ensuring fairness of machine learning models and outcomes, KP could well become the Disneyland for data scientists. So that's the introduction to KP, Kaiser Permanente.
That's awesome, Tomi. Thank you for that. At CognitiveScale, we couldn't think of a better client to work with for a lot of the reasons you mentioned, from your coverage across the industry, the country, your membership size, data science skills, and when I introduced myself to you, I said I was a Kaiser member for over a decade. So during my time in Denver, frankly, I miss it. It was a great time, and I'll cover off some more of that later, my personal experience there. But in terms of the agenda here, let me take just a few minutes to set the context here for the challenges that healthcare is facing with regards to trusted AI, the topics at hand, explainability and bias in ML models, and then we'll get into a quick view of my company, CognitiveScale, our point of view on trusted AI in healthcare, some of the use cases, specific components of trust, that we pay attention to, and we're helping organizations like KP to evaluate. And then we'll get into the cool part of this discussion, the topics at hand around Kaiser Permanente and Tomi specific use cases here, and some of the goals that you're trying to achieve with your programming and assessments, Tomi. So, we see headlines nowadays. Healthcare organizations have had some high-profile run-ins, if you will, related to trusted AI, where models have been shown to be biased. AI solutions and ML models have earned a bit of scrutiny from regulators, in cases where care was denied to populations based on racial bias. AI solutions have come under the scrutiny of regulators and clinicians. Clinicians need to trust the accuracy, obviously, the bias and the training data, those sort of challenges. So there's also explainability around black box. So as healthcare organizations have looked to leverage artificial intelligence and machine learning to increase digital automation in decision making, lower costs, serve patients, drive better outcomes with AI solutions, trust has become that much more important. Doing so without, propagating bias and fairness issues and that sort of thing. So, today, obviously, we want to talk about some specific use cases. Tomi will dig into with us what Kaiser Permanente is doing with explainability, breaking into the black box solutions to do things like allow physicians to trust that diagnostic solutions or care allocation, discharge decisions, use cases like this can be trusted, and to see if there are ways to uncover bias in underlying data and algorithms. But we also just want to point out, we're helping organizations in areas like effectiveness, ensuring digital decisions and models are continually generating optimal business value. We're looking at data drift, helping with compliance and robustness, a number of areas, all in an effort to reduce the impact of trust issues with AI. Things like reputational damage, revenue loss, regulatory backlash, criminal investigations, customer privacy, and diminished public trust. So it's a pretty daunting list, obviously. And at CognitiveScale, we've even developed a solution, Certify, to it. It really, enable the deployment and monitoring of trusted AI solutions and ML models. So our Certify product can do things like automatically detect and score data and model vulnerabilities and help it with questions like, how did a system predict what it predicted? The explainability metric, if you will. If a person got an unfavorable outcome from a model, what can they do to change that, leveraging counterfactuals? Has an AI system or model been unfair to a particular group, that fairness or bias metric, and how easily can a model be fooled in terms of robustness? So Certify's then providing not only results for different businesses and IT stakeholders, but a unique trust index where we're helping to calculate a score, if you will, for each of these components. And as a healthcare subject matter expert at CognitiveScale, I'm helping to manage the subset of that around a healthcare trust index for a number of use cases. If we really want to get to Tomi's specifics, his several, but we're talking about things again like those that have made headlines: denial of care and care management program matching, patient discharge where there may be bias, in terms of diagnosis and treatment, accuracy, effectiveness, explainability, that black box problem where clinicians need to trust the solutions is common. And even in things like sales and enrollment, how organizations are matching clients to products, pricing, where there might be discrimination, a lot going on in this area. So let's get to the good part of the discussion, really. Now somehow I've lost your list, Tomi, I'm sorry about that. But I really want to get into explainability and bias in ML models at Kaiser Permanente. But Tomi, first, before we get into the specific use cases, a key question: why is it important for KP to be able to evaluate AI models and solutions for potential bias or fairness and explainability issues? And what are your goals and needs with these AI assessments that you're doing?
Absolutely. So thanks for that question. So all of those ones are extremely important for Kaiser, the bias, fairness, etc. And let me just go a little bit into the history and what Kaiser is doing and overall in making sure that we are providing equitable care. For the entire history, 75-year history of Kaiser Permanente, our mission and foundational values have led us to embrace diversity and pursue equality. And KP started in World War II shipyards with women and men, including those of color, working as equal members of teams. In the 1940s, when some of the hospitals were segregated, Kaiser's hospitals, both the care teams and as well as the wards were integrated. And so we have a long history with that. And we have a long history of doing a lot of work in making sure that we're providing equitable care. Already 10 years ago, we had equity dashboards that were looking at the performance of our screening measures and control of cholesterol, blood sugar, blood pressure, etc. And we had initiatives to improve many of those measures within specific populations. As an example, we've had efforts geared towards improving colorectal cancer screening in Latinx men. There's been many occasions when we had to think creatively in how to reach out to these specific racial and ethnic groups. For example, we recognize that barbershops have become so culturally integral to Black communities that we decided to train barbers and hairdressers to ask their customers if they had their blood glucose tested. And then we had mobile vans to provide many of those testing services so that it would be easy to access such services. We've done lots of cultural sensitivity training. As a matter of fact, even tomorrow, we have Latinx Mental Health and Wellness Virtual Summit internal to KP, where we are teaching and supporting our KP's mental health care providers in advancing health equity for underrepresented communities. And even people who don't come in contact with our members have many training opportunities and I've, for example, I've taken many of those trainings. We also do hiring with the diversity in mind, and we've done that for years. While we hire for the most qualified people, interviewing many qualified minority members allows us to find and hire providers and service personnel who look like and speak the languages of our members. We believe that we get better results when the people our members encounter mirrors the diversity of our member base. Even outside of the patient care roles, we get better performance from a more diverse thinking in our employee base. The COVID-19 pandemic really demonstrated the inequality with data showing that Latinx and African Americans are disproportionately affected by the disease as well as by its economic impacts. KP's efforts in this area include developing and publicly sharing a COVID-19 social health playbook to provide guidance on addressing the indirect social impacts of the pandemic and the conditions that give rise to inequity and racism. In addition, we have supplier diversity efforts. We have established Health Equity Advisory Council. We have won many national diversity awards. I could go on in describing all of these diversity efforts at Kaiser Permanente, but I just wanted to, it was a lengthy kind of reasoning, but I wanted to give all of this context because it's important to understand, again, this is really core of Kaiser Permanente in making sure that we provide the best possible care for every member of ours. So in terms, now coming back to your question about importance of fairness in machine learning models, the simplest answer is that failing AI ethics, which is kind of the category where I would put the fairness argument into, can expose KP to reputational, regulatory, and legal risks. But that's not the main reason why we work on this. The more importantly, failing to operationalize data and AI ethics leads us to wasted resources and inefficiencies in product development and deployment. And we want KP's physical data and other resources to go where we can have maximum health impact for our members and communities. If you don't consider fairness, we'll not be able to achieve that. But most fundamentally, it is against who we are as a company. KP has a history of working towards advocating for equity, which is where we started this discussion from. So there's a lot of evidence of potential unintended consequences if the models are not developed with care and consideration of fairness. For example, many of you know that Optum is being investigated by regulators for creating an algorithm that allegedly recommended that doctors and nurses pay more attention to white patients than sicker black patients. So these kinds of things rise to prominence, and we really have to put the utmost care in making sure, again, our models are representative from the data perspective, from the algorithmic perspective, and also that we get the right outcomes of our efforts as well.
That's great, Tommy. Very impressive. Thanks for all the details and the insights into KP. I did not only tell you I was a member, but also my wife worked at KP that whole time. So, for over our decade in Denver, I knew a lot about the organization's values and ethics you've mentioned. And I'm well aware of how strong the organization was, these values. It's really a unique healthcare system. So I can see, how these challenges have to be top of mind for you, since, ethics and trust are really a part of the KP DNA. But can you elaborate a bit then on the, we talked about assessments, trusted AI assessments. Can you elaborate a bit on that?
Yeah, and so you want to talk about sort of your wheel of that includes other things beyond the fairness and bias. One thing that really is important to us right now is explainability, and it's an explainability of our models. It can help with the fairness and bias itself, but it's important from other perspectives as well. So healthcare is a great place to create analytic products because it's filled with people, particularly the physicians who have taken medical informatics classes as natural part of their education and who have been trained to ask and collect more data prior to drawing conclusions. So they're data driven by nature. But it also means that they do not necessarily immediately believe the data and database recommendations that they've been provided until they build their own comfort level with it. And so we need tools and systems to make them comfortable with the models and the outputs. We need them to have the opportunity to review and alert us if something doesn't seem right. When possible, the products need to give the care providers with the ability to verify for themselves during the use, but particularly in the very beginning stages of the use, when they're getting comfortable with the analysis, verify why is the recommendation what it is, and we've observed that it increases significantly the adoption rate, and then again the outcome and then the quality of the care if people have good comfort level with the models. So unfortunately, building trust into products is complicated, and each healthcare model is different. We are very lucky to have diligent analysts and sophisticated physician customers for many of our models, and those physicians that have been trusted to oversee our models are first rate. But we need the plan of developing this explainability and fairness in a scaled way, and one of the things that we're doing for that is we're currently conducting this kind of pilot with CognitiveScale and exploring what CognitiveScale might be able to provide for us.
Yeah, great. Well, and like I say, we couldn't think of a better organization than Kaiser Permanente to get into these pilot use cases. So let's transition to those. I've managed to delete a slide and just turning this on. So if you don't mind, while you get into the 3 use cases, Tommy, I'm going to just add a slide and put those titles back in so our viewers can see each one you're talking about as you go through them. But if you'd take it over, I'll leave it to you to dig into those. Yeah.
Yeah, I don't think that that's the necessary. I think we can talk through them. So
Okay,
we can talk about 3 use cases, kind of in a different stages of use, production, development, and so forth. One is in production use, another one is currently being developed, and third that we are thinking about, and that could potentially become monumentally important. It is very complex, so we can talk about those in a moment. But before we sort of go into each one of the use cases, I wanted to just kind of talk a little bit about what sort of applies to each one of these use cases in terms of the observed fairness issues. So, so when we have been doing sort of fairness bias analysis with these ones, and we've been exploring it elsewhere as well within KP, for many situations we haven't observed significant fairness issues, but we really want to go deeper. And I think that the explainability can really be a game changer, is making providers comfortable and again and confident in this custom and in the use of these models. So touching a little bit of the challenges over the last 2 years, there's kind of been 3 formal definitions of fairness, and I'm sure that there are many more than this, but there's some things like anti-classification. So you want to make sure that the predicted attributes like race, gender, and their proxies are not explicitly used to make decisions. That's one of the ways that people are defining the fairness. The other one is classification parity, which means that the common measures of predictive performance, like for example false positive and false negative rates, are equal across groups defined by the predicted attributes. And then the third one is calibration, and that means that conditional risk estimates, the outcomes are independent of these predicted attributes. And there's some issues with these objectives for healthcare. For example, the anti-classification piece, there are genomic differences between the groups. So if you think about sickle cell disease, for example, is much more common amongst the African Americans, and there are a whole host of genetic diseases for Ashkenazi Jews. They're much more prone to culture disease, Tay-Sachs disease, etc. And more is discovered all the time in genomic research. So maybe rather than trying to sort of create a same algorithm for everybody, and then diluting it to try to make it achieve exactly the same decisions or recommendations, we might achieve better results for everyone if we acknowledge it and train separate models for those with predicted attributes. But it must be done carefully and thoughtfully to avoid any kind of unintended consequences. So objective is to ensure that every group will get the best possible outcomes, and every individual gets the best possible outcomes. So ensuring fairness may require additional efforts to collect additional data and potentially identify different outcome variables. About 10 years ago, KP collected 500,000 tissue samples from volunteer members towards our sort of genetic tissue sample database. And we recently went back and collected more to improve the numbers of the underrepresented populations. And so we're doing a lot on the data side of things to make sure that we'll bring in enough data. Also, increasingly, we're incorporating things like social determinants of health into algorithms, both as input variables as well as alpha variables. For example, knowledge of food insecurity and homelessness or history of it can help us in tailoring healthcare interventions, and as well as connecting with the right kinds of services. So those are kind of the use cases on a more general level. So if we want to go through the couple of use cases that we have here. So emergency room returns predictive model is one of the sort of it. We have that one in production right now. So last year we were conducting analysis on individuals who come to emergency room frequently, and for many of them, while unfortunately it's appropriate, and as their conditions change quickly, and emergency room is really the right care setting for them. However, we also think that there are opportunities in identifying those who we can take better care of in advance. If we can identify them, we can take care of them in advance so that they maintain the control of their conditions. And we decided to calculate the return probability to ER for all of the members in our regions when they're in ED or ER. And we calculated for 7 days, 15 days, 30 days, and 60 days, and we use them for different purposes for the different time frames. We used previous utilization and illness burden and some demographic variables in these models, and we achieved 0.85 area under curve performance for some of these models, and this model has been operationalized to better care some of our complex care patients and identify those ones who need to be acted right now on. We used AutoML to train this model, and we could continue using it for inference as well. So AutoML is an important component of this one. We got some information about the feature importance from the SHAP values, but I think again we need more robust explainability, fairness bias capability, and we're sort of exploring that area right now. So that's one of the use cases. And then shall I go through the other two use cases as well?
Yeah, sure. I'll just mention quickly. I mean, we are engaged with Kaiser in terms of things like healthcare interventions, even those ER risk models in the practical application, as well as this, understanding explainability. So appreciate your level of detail on that. But yeah, the second use case around social health risk scores, that'd be great.
Yeah.
Too.
Yeah. So we have actually multiple efforts going on to build models to identify those who have high likelihood of currently experiencing social needs, such as homelessness or food insecurity. But we're also looking at risk of developing those kinds of needs in the future. And it would have been great if this kind of model was operational this spring when the states were providing hotel rooms to homeless to curb the transmission of COVID-19. If we had a very good way of identifying the homeless people, we would have been able to get them quicker and with sort of less effort into those hotel rooms that were provided. We have some training data challenges with these models, and we're working with some proxy measures. Social needs have not always been collected consistently, and they come from sort of various different data sources, and we're improving on sort of consistency on this data quickly, but there's some challenges that we have with it, and as you can guess, there are a lot of potential bias fairness issues here in terms of how do you identify somebody being potentially homeless or somebody having financial insecurity and so forth. So we have also, in addition to the sort of AI and machine learning, these models that we're doing, we have lots of sort of non-AI processes in place to ensure that we're doing our best in the fairness area. So we can't leave many of these things to sort of to computers only to look at it. We have to look at the other aspects as well. And then an area which we are just starting to explore right now is is pharmacy analytics. We're looking at and trying to understand how our pharmacy prescription happens right now, and we're kind of looking at some specific specialties. And one thing that could potentially be a sensitive topic, but what could potentially also be a really fruitful topic area is if we could figure out, based on sort of information in the electronic medical record and whatever else we can get from the patient, if we could figure out what is the likely prescription that the physician will be writing for that particular member when they come and visit us, I think that would give us a great deal of opportunity in supporting these physicians in the journey. And many times, obviously, there are very good reasons why their prescription is different from what the model is expecting the prescription to be, but at least we would have some level of indication on what would we expect such a prescription actually to be. So anyway, those are a couple of the use cases that we've been exploring.
And I've got a couple of questions for you on those. I'm curious on that third one, the pharmacy predictive model. What can you possibly elaborate? I know it's early days with that one. This may be hard, but like what might be some bias and fairness or explainability challenges with that?
So I think that I think it's kind of applies to many of these things. As I mentioned previously, there's some of the things that might be driven by genetics, some of the things that might be driven by environmental factors, some of the things that might be behavioral social factors, and sometimes depending on when you include some of the, let's say, demographic variables into these models, the models might actually depend on your training data, might actually expect certain things. But now you have to make sure that again, you don't use whatever has been the historical precedence. You don't use that one to predict that what specific predicted group, what kind of prescription they would actually be getting, unless there's some sort of again, genetic or other appropriate reason for it. So everything has to really be thought through in a very careful fashion.
Yeah, we see quite a few of these use cases where if it's a clinician, say a physician related to prescriptions, in this case, that black box solution needs to be completely trusted, or their skepticism, the lack of explainability becomes an issue. So I can imagine this applying there. Sure. So thinking about the first couple you mentioned, the emergency room predictive model and the social health risk scores, and I guess even this third one, but in terms of a trusted AI assessment, can you tell us a little bit about what you're doing with these assessments?
Yeah, so we first of all, we'll really look carefully at the data in order to make sure that we get to a representative sample and something that is conducive to what we're trying to achieve. Then we also use Shapley values when appropriate, and to understand the contribution of the different features. And then again, now we're sort of kicking off setting up a pilot with CognitiveScale. Hopefully there will be other things coming from there. From actionability perspective, we're particularly excited about the counterfactuals if they will pan out for us. I think that'll be actually very exciting to come up with ways to, again, identify if you actually had for that, whatever that individual was, if they're one of the variables there were slightly different, how would you have gotten a different result? And obviously there are certain things that you can't really do much about. If they say that okay, it's an age, you can't do that much. But if that variable that gives you that counterfactual, which says that if you just had changed, I don't know, the exercise regimen or specific drug that they have been prescribed, and if that was changed, and your predictive model might actually have predicted a different result, I think that can be enormously beneficial for us, again, from the actionability perspective.
Yeah, no, if I could elaborate a bit on that, my understanding of some of the Kaiser work there with counterfactuals, which is really interesting to me. You have examples like you've mentioned, these risk scores that might have dozens of input variables where, say, a clinician, a case manager might be utilizing algorithms that are helping make decisions for hundreds of patients a day. So how do they know which few variables to key in on for a given patient? Can those counterfactuals, light up some key considerations for them? It's really interesting stuff. Gets to that sort of effectiveness part that I was talking about in terms of our skills around trusted AI and even the components of the trust index. So, but yeah, your use of counterfactuals should be a really interesting use case. And what about, Tomi, then the the ongoing monitoring of AI models? You talked about our pilot and establishing a platform. I mean, there you have what we've talked primarily about today is the use cases and specific, ML with possible explainability or bias and fairness issues. But now to deploy it across an organization of Kaiser's side and the practical application of the use of not only the models, but these our certified product, the trust index, or even this one component. How about what are you thinking about in terms of ongoing monitoring of models and how you scale across Kaiser to use these tools?
Yeah, so there's definitely enormous amount of work going on in this topic area right now. We're definitely worried about drift and management and retraining, all of that kind of stuff. Scalability and all of that, those kinds of things. So but lots of parts of the organization are engaged in coming up with systems to monitor these models, and it's extremely important from where we will be talking here now as well, from that kind of fairness bias perspective as well, to make sure that our models are being managed well. So I'm not probably the foremost expert on that part of the topic matter, and I'm a little bit far away from sort of detailed technical aspects of many of the things that we've been talking about here as well. But again, I can say that again, it's definitely a topic of great deal of interest for us as an organization.
Yeah, no, understood. I mean, we'll take it a step at a time, this pilot phase. If we can hopefully revisit afterwards these several use cases you've talked about and what we're doing with specific measurements here, we'll come back to not only talk about that hopefully, but then we have, in the name of our company, CognitiveScale, scale in our name. So how an organization like yours can then leverage these, that'll be a topic for another day once we have some good results from the pilot. So very much appreciate all that. That's really the bulk of the questions I had for you, Tomi. I'll move it to Q&A slide here and see if we can open it up to the audience.
Well, thanks so much for that incredibly interesting and timely information. We have some really great questions for you, gentlemen. And the first one is a general question. What are the greatest untapped opportunity areas in healthcare right now?
Yeah, so obviously right now we have COVID-19 going on, and oh boy, has it been an exciting time from the analytics perspective. The number of models that we have seen and the sophistication in topic area that wasn't really that much used or explored on a day-to-day basis. So I think that COVID, from our perspective, it is about making sure that we have all of the resources, the predictive equipment, and everything else in the right place at the right time. If we can figure out that kind of things, we can do what we just discussed about helping our members with the social determinants of health, the social health playbook, and all those kinds of things. But for more broadly, from I guess from the societal perspective, there are lots of good modeling opportunities here relating to the policy, and now that the vaccines are coming, the vaccine distributions, and many just exciting analytics opportunities in this space right now.
You know, one of the really interesting things that drives my particular mission, you know, in addition to being the moderator, I host a show called the Cyberhero Adventure Show, and we've just created a superhero comic called Defending Your Health. And in a couple of weeks, I'm going to be the master of ceremonies of the Health ISAC convention. And one of the things that that we really try to do is to distill complicated technology information into entertaining and easy to understand stories. How would you explain to a person not steeped in AI and machine learning what the black box is?
What the black box is? That's a good question. I don't know if I would go there from the sort of deep learning and deep neural network perspective and describe how many layers you have in between your input and output variables, and how complex it can get in terms of the number of connections and nodes, and how that scale will automatically make it almost impossible to understand how the model actually calculates the output. So maybe that would be sort of the black box illustration of our example that I would describe from the comic book perspective. I'm sure that some people can come up with better options than that one, but that would be my first thought.
I guess what I would add to that is, you know, one key areas are the clinical applications. So, you know, things like diagnosis in pathology or radiology, where, you know, there are headlines almost daily, at least weekly, around, you know, really cool AI solutions helping, you know, read slides at 1 million by 1 million pixels and detecting, you know, breast cancer much earlier, delivering all kinds of results, or radiology use cases looking at scans and imaging. These are areas where you're augmenting the intelligence of a clinician. And so if it's a black box, you know, they are rightfully skeptical. There have been plenty of these examples that have been shown to have bias. You know, skin cancer algorithms train initially on people who go to dermatologists, and that's only a subset of the population. So, you know, those black boxes have to be cracked open a bit and give clinicians confidence, you know, allay their fears or lack of trust and skepticism. So that's just one big area where AI solutions are doing great things, but you've got to, earn the trust, rightfully so. And then, you even come up with specific challenges like what is accurate enough in that world, model to model or solution to solution. And you've got to remember a lot of these capabilities might be built into a machine that you get from a third party, when you're talking about lab or radiology, oncology, cardiology use cases. So earning physician trust can be a challenge. That's just something the general public reads about it every day. Another big area is just around regulators, what gets companies in the paper. You can read a lot about discrimination in lending or credit cards via AI solutions, but that's happening in healthcare as well, where organizations are getting in trouble because they're leveraging biased models to make decisions on what kind of care they cover, things like that.
It's something that you mentioned there, which is the ability to diagnose things from scans where human eyes could not detect things. There are a bunch of different kinds of ethical issues, sort of beyond the sort of what fairness and bias discussions that we have talked about that come into play over there. First of all, sometimes we actually are now developing the capabilities of detecting perhaps like cancers so early that they, at that point in time, they're so minuscule that there's certain level of spontaneous remission. So your body actually, even though it's a cancerous start or at least indication of that one, now the question is like, do you go and operate on those people, and if they actually didn't need it? So that's one sort of ethical complexity issue that arises. So the many such topics that arise when you create these kind of capabilities.
Indeed, and you had mentioned about trust, and the only time you hear about kind of cybersecurity or data privacy is when the criminals win. Maybe you can share with our audience a little bit about how you incorporate data privacy and cybersecurity, in your data.
Oh yeah, absolutely. We have enormous number of data scientists working in our cybersecurity function as well. I don't even remember how many million sort of attempted break-ins that we have on a day-to-day basis, or it's just a very large number, sort of that we have to continually be on our heels and protect ourselves against cybersecurity. So it's an ongoing sort of race to make sure that we can stay ahead, and these days I think it's in big part we have to use the AI to detect some of these efforts to break into our systems.
Yeah, thank you for that. A questioner asks, can the sequential synthesis method work well for replicating large data sets in healthcare studies and research and still minimize or even compensate for possible AI biases?
Sorry, but sequential, it might get too technical for my small brain over here. But can you repeat that?
Sure. Can the sequential synthesis method work well for replicating large data sets in healthcare studies and research and still minimize or even compensate for possible AI biases?
Okay, I'm not actually technically qualified. I don't actually know this particular technique, so I'm not qualified to answer that question.
I'd have to also bring it. That's over my head as well. I'd have to bring in our experts on that one.
Okay, well, maybe the questioner can provide a little more context, or we'll make sure to get back and address that very important issue. What sort of new data sources have you seen driving some of the more interesting outcomes lately? Like Sensor data appears to be exploding, on the clinical side of the house, as does imaging. What are you seeing on the horizon?
You want to speak to that one, Tommy? Or I can a little bit.
Go for it.
Okay. Yeah. So first of all, I'd say Kaiser Permanente is a bit unique from our usual customer because, an integrated delivery network there, the provider and the health plan. And so that member is also a patient and, with Epic assets and access to clinical data, they might be different than, say just the provider or just a health insurance company. So it's a very good question. I mean, we talked earlier about things like healthcare interventions, and when you try to change the trajectory of a member via, better understanding of their risks with risk scores, likelihood, predictions, deliver personalized insights, that really do change that trajectory. Obviously, you need a lot of data. So you see health insurance companies trying to get more EMR data on patients, get them to use apps that collect more of that data and those sorts of things. Obviously, apps and smart devices in home care, COVID-19 has especially accelerated that. So edge devices, not just phones and laptops, but smart thermometers and everything you can imagine. And then even just the use of those tools, like how do we reach our members? Which ones use their phone and the app on it versus, say, call centers and those kinds of things. So, and then organizations like Kaiser Permanente, you heard Tommy say, getting to genomic data, understanding your members and patients at a atomic level, if you will, is really interesting. And that's kind of the ultimate in personal service. But we're seeing our clients leverage all of that. So it's, clinical, administrative, financial, demographic data. It's internal to the organization and external, with COVID and weather data and government healthcare models, public health resources, all those sorts of things. Orchestrating all of this data, it's kind of a core competency of ours and our solutions. But in order to drive these sort of AI solutions, if you will, things like personalized interventions, you've got to have the wherewithal, and healthcare, historically has had all kinds of challenges with interoperability and getting access to all that data. But it's really obviously the foundation for personalization. And
wow.
Then, yeah.
Well, on behalf of a grateful nation, a grateful globe, actually, thank you for what you and all your unsung heroes, do every day to take care of, our country, and for the selfless service that you provide to keep everyone safe and healthy. So on behalf of everyone, thanks so much to Tommy and Jeff for the opportunity to learn from their years of leading edge experience. We could do hours and hours and hours on this. We have a couple questions that we'll be able to follow up and get back to you on. As I mentioned, we have 4 lucky winners for today's $100 Amazon gift card giveaway, and they are Christine D, Gail M, Lynn B, and Gail M, I guess another one. Somebody from the DevOps team will send you an email to confirm your email address and get the gift card over to you promptly. And as I mentioned, this webinar was recorded and the slides will be available on demand at devops.com in a couple of hours. And we'll be sending you a link to the slides and recording as well. Thank you so much for spending an hour of your valuable time. We truly appreciate it. And we hope you all stay safe. Have a great day.
Thank you.
Thank you, Gary. Thanks, Tommy.